Good afternoon. I'm Dr. Nicholas Silvestri, graduate of the class of 2004, president of the Medical Alumni Association, assistant dean for academic and student affairs, and associate professor of neurology. On behalf of the Jacobs School of Medicine and Biomedical Sciences and the Alumni Association, we welcome everyone who is joining us for our first virtual Spring Clinical Day, featuring keynote speaker Dr. Roy Vongtama and Dr. Michael Kane, Vice President for Health Sciences and Dean of the Jacobs School. Spring Clinical Day began over 80 years ago. It's the premier event of the Jacobs School, and we continue to be proud of bringing everyone together all over the country and serving as a forum for our accomplished alumni, students, faculty, and graduates. Today, we also honor distinguished medical alumnus, Dr. William Adler, class of 1965, and our distinguished volunteer of the year, Dr. Randy Loftus, class of 1992. Dr. Adler, who is also celebrating his 55th reunion this year, is former chief of clinical immunology at the National Institute on Aging in Baltimore, Maryland, and a past professor of immunology at the Johns Hopkins University. We are proud to recognize Dr. Adler for his distinguished career and expertise in the fields of immunology, pathology, and infectious disease. His work at the NIH and Johns Hopkins University has had national and global impact. Throughout his career, Dr. Adler has conducted research that has enhanced our understanding of immune deficiencies in both the pediatric and geriatric populations. His influential research, as well as his success as president and founder of the Wiltshire Associates, a company that provides information to individuals investing in the biotechnology field, are notable. Congratulations, and we wish you very well, Dr. Adler. Next, Dr. Randy Loftus is the 2020 Distinguished Volunteer of the Year. It's a privilege to recognize my friend and fellow board member for his generous, ongoing support of the medical school, alumni, and students. UB is a better place because of Dr. Loftus' dedicated leadership and unwavering commitment. We are so grateful for the time and effort he devotes to supporting programs like our Alumni Association, bringing students and residents together. Programs such as the Alpha Omega Alpha Honor Society, mentoring, honoring our volunteer faculty, athletic gatherings, philanthropy, and much more are those that Dr. Loftus has been involved with. His ongoing willingness to assist us in engaging our constituents across the board is inspiring and represents a level of service we are extremely fortunate to have. Your support of the Jacobs School and the Alumni Association means so much to us, Dr. Loftus. Thank you for everything that you do for our school and your patients, and congratulations. I'd also like to congratulate our reunion classes. In particular, we'd like to acknowledge the class of 1970, whose members are celebrating their 50th reunion via Zoom later this evening, and they will toast 50 years to medicine. Now it is my pleasure to welcome and introduce the Vice President for Health Sciences and Dean of the Jacobs School of Medicine and Biomedical Sciences, Dr. Michael Kane, who will introduce our keynote speaker and provide an update on the school. Dr. Kane has served as Vice President for Health Sciences at the Jacobs School since 2011 and Dean since 2006. In his Health Sciences role, Dr. Kane leads the university's 5 health science schools, which in addition to medicine and biomedical sciences, includes dental medicine, nursing, pharmacy and pharmaceutical sciences, and public health and health professions. Please join me in welcoming Dr. Kane.
Thank you, Nick, and good day to everybody. I'd like to begin by thanking Nick for his service as president of the Medical Alumni Association during the current school year. The work that Nick and the governing board and all of our alumni, what they have accomplished is making an important difference for our school and for our network of graduates. I would also like to extend my congratulations to Drs. Adler and Loftus for their achievements and to express my gratitude. We are honored to recognize you both and add your names alongside our past Distinguished Award recipients on the school's Distinguished Wall of Fame in our new Jacobs School building. For 174 years now, the Jacobs School of Medicine and Biomedical Sciences has educated physicians and scientists who have made significant contributions to healthcare through healthcare delivery, their research accomplishments, and the education of undergraduate and graduate physicians. As Nick said, I've been asked to spend a few moments providing a current state of the school, and I'm going to try to do that in the context of the world that we live in. So let me first begin with education. As you know, our school is accredited by the Liaison Committee for Medical Education, or the LCME for short. These are 8-year cycles that every school is accredited and then reaccredited to serve as an actual medical school. So we had our 8-year site visit last April in 2019, and in October received the good news from the LCME that we're fully accredited. We continue our accreditation for the full 8-year cycle. We have some homework to do, as does every medical school across the country, and this is homework that we have been working toward because it's been coming and needed for several years, and that is curricular revision of all 4 years. And so in preparing for that curricular revision, we have done several things. One is we purposely built the new Jacob School building to accommodate a wide spectrum of educational venues that would make it easier to revise the curriculum and use every teaching venue that we have now and have in the future. We also established the Medical Education and Education Research Institute, or MARY as an acronym, and recruited a nationally recognized scientist really in medical education, Dr. Jennifer Mecca, who joined us about a year ago. And through MARY and the Office of Medical Curriculum, we continue to increase our expertise in individuals with expertise, as I said, in curricular design and curricular assessment. We've expanded our interprofessional education program, and in fact, it received national recognition in 2019 as a program of merit from the Association of the Schools of Advancing Health Professions. So let me put that in a parking lot for the moment and then add the impact that COVID-19 has had on our medical curriculum and our medical students during the last 3 months, and something that will continue to have an impact on them for years to come. So pretty quickly, with about a week's notice, our faculty had to convert every classroom and lecture-based component of the curriculum across all 4 years into a distance learning format. And it was a remarkable accomplishment over a very short period of time. All of our required and elective clinical rotations, the classic clerkships of the 3rd year and the subspecialty electives in the 4th, all had to be paused since the middle of March. So we've not had a 3rd or 4th year student see or interact in a clinical setting now for 3 months. We had to redesign the 3rd and 4th year curriculum in a very short period of time. We were able to successfully alter the 4th year curriculum so that we could fulfill all of the learning requirements of the 4th years who missed the last 2.5 months of their clinical rotations. So all of our 4th year students were able to graduate on time. We did this on May 1st through the first ever virtual graduation. And we were pleased that 36 of the 147 graduating students matched and elected to do their residencies at the University at Buffalo. We had to then also adjust what will be the new 3rd year and 4th year curriculum to allow the current 3rd years finish their clinical rotations, then become 4th years, and then change to the 3rd year so that the new current 2nd year students, when they become 3rd year students in the summer, can fulfill what they need to during the last 2 years of medical school. So we are now able to bring our current 3rd year students back so they can finish their 3rd year, and the students are returning to their clinical rotations on June 15th and will finish the 3rd year at the end of July. In July, those third years will become fourth years. The second years will become third years. And on August 1st, both years will begin what will be a modified third and fourth year curriculum that still allows our students to learn the learning objectives that we require of them to graduate. So although the COVID-19 pandemic has caused a remarkably significant disruption to all of our education programs, on the good side of it, it forced us to actually change the way we deliver education and used modern day video and interactive and distant learning modalities. It forced us to actually admit that we could change the third and fourth year curriculum and still satisfy the requirements that are needed for a student to learn to graduate and be capable to being a physician in their graduate medical education, and to apply what we learned in a crisis mode to the longer work done by several committees to totally revise the curriculum, as I said at the beginning, and have a new curriculum, a redesigned curriculum, available to our students in the fall of 2022. From a research point of view, our portfolio of basic and clinical research support from the NIH now is larger and stronger and more broad than when I first came to Buffalo in 2006. We continue to recruit outstanding scientists and physician scientists. We've just hired a new chair in physiology and biophysics who is joining us from Johns Hopkins University on July 1st. On June 1st, just last week, a new chair with expertise in reproductive endocrinology joined us from the University of Utah, Sarah Berga, as chair of OBGYN. We have a new director of our MD PhD program who also joined us last week. And about a month ago, Dr. Roberto Pili from Indiana University joined us as a physician scientist and a new division chief of hematology and oncology in the Department of Medicine. Our Clinical Translational Science Institute went through a successful competitive renewal and is now renewed for 5 more years. And a primary focus of our Clinical Translational Science Institute is healthcare disparities. Leadership of our Clinical Translational Science Institute and UB joined with our community to establish the Health Disparity Research Institute to facilitate the focus of this grant's work on helping to have a favorable impact on healthcare disparities, as you are aware. I want to just mention that during this whole period of time, we've had to pause all of our basic and clinical research. And this was both to protect our own health, as well as the public health involved in clinical trials. And all of those basic and clinical trials have been paused with the exception of work dealing directly with COVID-19. Beginning just last Monday, we got the approval from the state to start to reopen our basic and clinical research programs and to re-engage then in research broadly and fulfill the specific aims of the NIH funding grants that we have. Going back to the focus of the Clinical Translational Science Institute, which, as I said, is a focus on healthcare disparities. When that grant was written and the funding is to support doing work that solves healthcare disparities as traditionally thought, and these are, do everyone in the United States have access to healthcare? Are the outcomes different in a person who is African American or Caucasian, and to focus on trying to improve those healthcare disparities? Recent events in Minneapolis, Georgia, Buffalo last Thursday night, and around the nation, all of which upset, anger, and sicken us have made it very clear that health disparities, as traditionally defined, are only a part of the consequences of racial injustice and inequality and bias. Our Office of Inclusion and Diversity continue to expand the abilities of our school with our students and our staff and our faculty to do everything that we can to improve these inequities and injustice. So let me just end this brief summary of the state of our school by saying that today, June 6th, our school has been shaken, it's been challenged, but we are absorbing and responding to the financial, the programmatic, and the emotional impacts of the COVID-19 pandemic, a bad economy, and racial injustice and inequality that cannot be ignored. In the end, people define the character of an institution, and people make an institution great. Our students, our staff, our faculty, and alumni are resilient, tenacious, and devoted to improving the public health through education, research, and healthcare delivery. We are a resilient 170-year-old institution, and we will fulfill our goals. I promise you that. And finally, if I looked at what is the ultimate impact of COVID-19, it is on people in my age in the institution are trying to decide who best has a hair length that seems to be the way our hair looked in 1975. So we had just learned last week that barbershops and hair salons have now reopened. I haven't been to one yet, but sometime this week, my hairstyle will return to the 21st century. So with that, I appreciate your time and listening. I am personally, and from my point of view as a vice president and dean, forever grateful and appreciative of everything the medical alumni do for this institution and all of our institutional programs. So let me end, and it's now my pleasure to introduce our keynote speaker, Dr. Vongtama, a Western New York native who grew up in Orchard Park, which is where I live. Roy is a board certified radiation oncologist and also an actor. He graduated from the Jacob School in 2000 and completed his residency at the University of California at Los Angeles. Roy currently lives and practices in Southern California. His research interest is in head and neck cancer. His ongoing work also includes hundreds of hours of study in nutrition, positive psychology, emotional wellness, and mediation techniques. Roy leads group mediators, mediations, gives public talks, and provides private coaching to individuals interested in taking more control over their health. So please welcome me in having Dr. Vongtama return to Buffalo, at least virtually. And the title of his talk is COVID-19, It Touches All of Us. Roy, welcome back.
Thank you, Dean Kane. I'm really glad to be here, and thank you for the introduction. And as you said, it's been a whirlwind time. Just as a little side note, we had planned to do a talk and we tested it on Wednesday, and every single slide that I've prepared is different from Wednesday to today. And that's just how fast we're moving in today's world. So let's get started right now and we'll just get into it. So the topic is the impact of emotion and trauma on health. But all of us, as Dr. Kane was saying, we're just overwhelmed. And are you feeling angry? Are you feeling frustrated? Are you scared? Are you just confused with what's going on, even as a practitioner, as a physician, but also as a person, as a citizen? Any kind of provider now is going to having a tough time just with COVID. This was the original topic, COVID-19. It touches us all. And then over the last few days, I realized that, it's about this movement as well. And we've had so many different protests. You remember just a few weeks ago, we had a protest for freedom. This is from the Michigan protest to unlock our country. And of course, now we're into a whole new phase of protest for the I Can't Breathe and the George Floyd movement. And unfortunately, it also made headlines in our own city as well. So, of course, this makes me feel overwhelmed. That makes me feel unsure, and I'm sure you're all feeling this. And instead of talking about COVID-19 specifically first, I wanted to talk about something that brought all of this to the forefront for all of us, and that's trauma. And so in a way, this is the name of the talk now. So what are we going to cover? We're going to talk about how trauma affects, how it links to disease, how it affects COVID-19, how you can help yourself, and how you can help your patients. First thing we have to do is define it. So trauma defined is a response to deeply distressing or disturbing event, can overwhelm your ability to cope, feelings of hopelessness, diminishes a sense of self, and affects the ability to feel the full range of emotion experiences. It can happen to children, it can happen to adults, but I've worked a lot with youth through my whole life in the inner city when I was at Penn in college, all the way through to foster kids here in LA, working with kids now with meditation. And I wanted to focus right in the very biggest study. It's called ACEs, the Adverse Childhood Experience Study by Dr. Folletti here in Southern California. It looked at 10 risk factors in 17,000 Kaiser Permanente health system patients in Southern California, followed over 15 years since that point. The breakdown is consistent with our population in Southern California. 80% were white, 5% were black, 5% Latino, 7.5% were Asian. And that's going to go into what we're going to talk about a little bit later, what's going on in these different populations. The thing is to remember, what are these 10 original adverse childhood experiences? The first one's physical abuse, emotional abuse, physical neglect, emotional neglect, sexual abuse, violence toward mother, substance abuse in the household, incarcerated member of the household, and parental separation or divorce, and mental illness in the household. So they were given a survey and given an ACEs score based on these 10 factors. So the question is, in this survey of 17,000 people that actually has been validated throughout the United States, what percentage of people had an ACEs score of 1 or more? Just take a guess right now as you're watching. What do you think? How many people had ACEs score of 1 or more? One of those 10 probably horrible things. If you look at the actual data, you can see here in the right column, 26% had 1, 16% had 2, 10% had 3, 12.5% had 4 or more. So 63.9%, 64%, basically 2/3 of all people had at least one ACE. So meaning you listening out there right now, as physicians even, as people in the community, 2/3 of us had at least one of these 10 things happen to us as a child. So what do ACEs lead to? What diseases does it lead to? If you look at this panoramic of diseases, physical injury, fractures, traumatic brain injury, emotional issues, depression, suicide, complications with pregnancy, sexually transmitted diseases, cancer, diabetes, abuse of alcohol, and unsafe sex, and socioeconomic decreases in terms of occupation, income, and education. What I really wanted to focus on, though, for us as physicians is ACEs and disease. So if you have an ACEs greater than 1, what happens? You have an increased risk of depression and anxiety disorder. Also, significantly related to COVID, adolescents who reported at least one ACE had to 1.2 to 1.5 times increased likelihood of being either overweight, obese, or severely obese when compared to people with no ACEs. So even just having one ACE, one or more, increased your risk for autoimmune disease. Now, that's very fascinating. We'll look into why that might be. Okay, if you had an ACE greater than 4, any kind of diabetes was increased. 4 or greater as well. 4 to 12 times increased risk in alcoholism, drug abuse, depression, suicide. A 2 to 4 times increase in smoking, 50 or more sexual partners, and obviously STD risk from that. Now, this group is a sad population. If you think of those factors, 7 or more, 51 times higher risk of suicide as a child or adolescent, 30 times higher as an adult. So these are ongoing chronic issues that are going on. Now my field, cancer. The risk of cancer, if you had these two specific ACEs, physical abuse or emotional abuse in the home or to you, it increased any cancer risk in 5 consecutive studies. And in this study, one looking specifically at lung cancer, it was increased with an ACEs score of 4 or more. Now, you might say as a physician, well, of course, they're going to be smoking because of all the things they experience. But even when they controlled for smoking and parental smoking history, the ACEs factor was still significantly present. This is an interesting study. Cervical cancer was linked to sexual abuse. So site-specific trauma, site-specific cancer. So how is this happening? This is something I've been looking at over the last 10, 15 years. In terms of cancer specifically, suppression of emotion leads to disease. This is, as physicians, a lot of times we don't get to express our emotional content when we're seeing patients all day. But even as people in our society, the emotional content oftentimes is separated, almost compartmentalized from the physical, mental, emotional, and it's to the side. You can even feel that in yourself. And over the years, and from the 60s onward, they started looking at different types of personalities. Type A, as you know, high stress, prone to heart attacks. Type B, more relaxed, prone to depression. But did you know in the 60s, they also at that same time were looking at a type C. Type C was a suppressive, repressed emotional state where you didn't express much emotion. And they found that in a study at Johns Hopkins of medical students, these students that expressed the type C actually had an increased risk of cancer. Now, this research wasn't carried forward not until recently, until the 1990s, where Dr. Timashuk found that a repressed coping style and a habit of putting others' needs first led that type C increased patients' cancer risk and increased stress markers. And more recently, in 2009, Dr. DeBoer found that in head and neck specifically, patients who are unable to express their anger, tension, or anxiety about their diagnosis were more likely to experience a recurrence. This is very interesting research. And this is why I developed this model when I work with patients, physical, mental, emotional, spiritual. They're all connected. They all matter. And they're all really important. And it's evidence-based that these connect. So hopefully you can see that from the research I just showed. Now, looking in terms of the George Floyd and the protests that we're seeing, this is the part that I really wanted to look at a little more in depth, because the original ACEs study looked at an 80% white population and looked at these 10 factors. In the expanded ACEs study, those 10 factors were in the home. The 5 additional expanded ACEs study looked at in the community. So if you think of your mind, the 10 in the home, 5 on the outside: racism, discrimination, being bullied, unsafe neighborhood, and poverty. This was looked at in about 1,700 patients in the Philadelphia area. In this particular cohort, 25% were at or below the poverty line. And if you look at the ethnic mix, very different from the original study. 41% were white, 43% African American, 15% Latino. So, as you might expect, compared to the original ACEs study, the expanded ACEs study had 5% more people with one or more ACE. So over 70% had an original ACE. And significantly as well, 13.5% had one of the 5 expanded ACEs without any of the other 10 original ones. So what are we saying? We're saying that over 80% of this population had at least one of the 15 factors. And if you look at a different data set, this is from the Department of Justice, 98.5% of urban youth have witnessed violence, which isn't one of the factors from the study. But if you can imagine, if you've seen that video of the policeman kneeling on George Floyd's neck, how traumatic that is to watch. I personally did not watch it because I didn't want to experience that. 98.5% have witnessed violence in person. So that's a big group of people experiencing certain sort of trauma. But as a scientist, it's really important to know what is the pathogenesis of this increased risk. And it really comes down to the limbic system, the amygdala, the stress response, and the hippocampus, which is involved in memory. These two areas have been seen to be most affected by these ACEs and this trauma. And what are we seeing? We're seeing a dysregulation of the hypothalamic pituitary axis. There's a dysfunction which causes a dysregulation in the response to threatening stimuli or a heightened response to stressful stimuli, almost inappropriately. Now you can see it in common parlance. Now you can say called, "Oh, I'm getting triggered." Well, that's really what's happening. Your limbic system is getting triggered by an event that reminds it of something that happened in the past. And what's the actual experience in the body? It's actually danger. Danger. You're feeling danger. You're at a heightened sense of danger. And it's a danger when maybe there's not really danger anymore. In terms of what you're actually seeing in functional MRI, they've seen abnormalities in the hippocampal structure, an increase in size in the amygdala, and a decreased size in the prefrontal cortex in the gray matter. So if you think about that, the deep part of the brain is becoming more active, and the cortical brain, which is the thinking part, the regulation part, is getting smaller. You're also seeing in the telomeres, a shortening of the telomeres. Telomeres are used, if you don't know, involved in replication of the DNA. Because of stress, these get shortened. Because of trauma, they get shortened. So what we're looking at is a really complex scheme. You can see even in this diagram. You have high levels of stress. You have telomere biology becoming affected. You have results of depression, which we know also affect the telomere length as well on its own. And of course, depression affects stress as well. And there's a genetic differential vulnerability to stress from person to person. What does that really impair? It impairs allostasis. Allostasis is the body's ability to regain balance or homeostasis. There's one more factor that we haven't even talked about here, and it's a new developing area. It's intergenerational trauma. Now, the research on this is actually in animal studies. So intergenerational, we're talking from generation to generation, from grandparent to parent to son. And if you think of the African American population, you can think of slavery as one of these intergenerational traumas. But the research on this, Dr. Diaz, who was at Duke, he looked at mice and he found that if you took a genetically identical mouse, subjected it to an adverse experience like a smell, an acetone smell, and they took the offspring, the sperm from these male mice, and replicated with the same female, they found that the successive generation of mice still experienced an aversion to the smell that wasn't coded in the DNA. If you think about that, so there was an intergenerational transmission of aversion from one generation to the next that's not coded in the DNA. So the mechanism for this is probably epigenetic, meaning outside of the genome. Is it non-coding RNA? Is it DNA methylation? We don't really know right now. But that is very interesting and showing some proof that this actually occurs. And what's hopeful in a follow-up study for Dr. Diaz, he found that trauma that they found in the R0 generation of mice, that trauma to that smell could be reversed. And if it was reversed in the original population, the trauma did not show up in the successive generations of mice. So that's very hopeful for us as organisms as well, as humans. So what's the result of all this trauma? What's the result of the impaired regulation? A term that they're using now is complex PTSD. So PTSD normally is from a single event like war or rape, usually in adults, where complex PTSD is from prolonged, repeated interpersonal trauma with little chance for escape. Exactly. Childhood trauma, living in an unsafe neighborhood your whole entire upbringing. It can happen in adults or children. So what does it actually look like though? You know, we just threw out a term, complex PTSD. So if you think about yourself now in this situation, if you're listening and you have any of these symptoms, it might be something to think about for yourself as well. even as a response to stress. It may not be that you have complex PTSD, but one thing, emotional regulation, which means like explosive anger, uncontrollable sadness, dissociation from emotions, especially around the traumatic history you grew up with. Saying, oh, it's not that bad. It's not that bad. My dad beat me. It wasn't that bad. I'm fine. Stuff like that. And then the triple population of guilt, shame, and blame, always there. If it's there in too much of a degree, something to look at, and mistrust of people who should be loved ones. And then also a distorted perception of the abuser. If you're abused by your parent, saying, oh, it's fine, I still love him, he didn't know what he was doing. And there's no actual perception of hurt or trauma around that. And I call this losing my religion. There's a loss of the belief in God or the loss of the belief in religion due to this kind of trauma. And on a basic level, there's an increased state of hyperarousal we talked about before, this feeling of danger. So what does that mean? Trauma in the end is a threat to physical, emotional, or psychological safety. It's a loss of choice. It's a dysregulation of the stress response. So that's about trauma. Now, almost forgotten about the pandemic. The pandemic, in the face of all this stuff, people forget we have COVID-19, but I wanted to look at COVID-19 in the populations that we're talking about here. And you look at the data, this is from 5/27/20. Look at the rate of mortality in African Americans. It is double of that of Latinos, Asians, and white. It's double. So if you think about that, what are we talking about? We're talking about systemic racism, an increased exposure. It leads to increased exposure because you have densely populated areas, residential segregation. A lot of them are essential workers, lower paying frontline jobs. And did you know that 30% of LVNs are African American? What does this mean? You're exposing, these populations are exposing multi-generational households because a lot of groups of families living together, grandparent, parent, children living together are exposed. And we know that the older the person is with comorbidities, higher rate of morbidity and mortality from COVID-19. They're further away from medical care, and they live in what we call food deserts. The grocery stores are further away. Overrepresentation in jails and detention centers. So think about that. Now we look at this is a very interesting slide. The sequelae from ACEs and the COVID risk factors. ACEs sequelae, increased risk for diabetes. What's a risk factor for COVID-19? Diabetes. Heart disease, ACEs. COVID-19, heart disease. Lung disease, ACEs. COVID-19, lung disease. Cancer from ACEs. Cancer, COVID. Autoimmune diseases, HIV. Immunocompromised state. Obesity, obesity. So you can see why this number exists. So it isn't just these diseases that are in the African American population. It's the trauma that has caused these diseases that leaves them open to this type of exposure to COVID-19. This is a second layer look at COVID-19 African American population. So in summary, systemic racism leads to trauma. Trauma leads to increased risk of disease. Increased risk of disease leads to worst cases of COVID-19. So it's so important for us as practitioners to really remember the limbic system. And then what I want to talk about now on a personal level for you and for me and for your patients is how do you get your mind from this deep part of the brain, from this limbic brain, into a more relaxed brain? How do you get yourself into a parasympathetic state? Or how do you get your mind out of stress? The research is looking at a word called resiliency. And resiliency, to me, I'll define it, and Merriam-Webster defines it the same way. It's the ability to bounce back to your original form. It's ability to get back to balance. And you can take me out of Buffalo, but you can never take the Catholic school out of me. I went from Catholic school from kindergarten all the way to 12th grade, so the Bible's in my head. So the answer is in the greatest spiritual scientist, maybe of all time. Jesus said, love the Lord thy God with all your heart, all thy soul, all thy strength, and all your mind. That's from the Old Testament. And then he added, love your neighbor as yourself. The key to that state, though, you have to know how to love yourself. And that's a lot of our problem, is that we don't know how to love ourselves. So we don't know how to give compassion to other people. So that is actually the secret is right there. We've got to give ourselves that compassion, that healing in order to be able to listen to what our patients are bringing to us, what our friends are bringing to us now in this time. We've got to create what I call bandwidth, space inside. You got to have that bandwidth. You've got to be able to have room for other people's hurt and trauma to come in. But you only have that if you've given that to yourself. So what does the research show? How do you give yourself bandwidth? How do you increase resiliency? Very simply, as you might expect from common sense, get out into nature, take your shoes off, getting out and seeing things bigger than you and than your mind. Also, add exercise to that nature, a 30% drop in anxiety, depression, and the stress response. There's also research in an area called blue space, meaning oceans, mountains, looking out into the sky. Even just doing that decreases the stress response on a regular basis. Taking a bath, there's research on that. You wouldn't believe it, but it's true. Adding essential oils, lavender, sweet orange, eucalyptus, and diffusers, or putting them into your bath. Taking a bath instead of a shower once a week, just once a week. There's research on actual expressive writing. I tell patients, especially cancer patients, to do what I call burn pages. I have them take scrap paper and write for 30 minutes straight without stopping. And I suggest you try that too. If you have a numbness or you have a feeling of overwhelm, just write. It's not writing to read, it's writing. I call them burn pages because I tell them if you have a fireplace, you burn it. You don't want to read it. It's getting it out of you. So, of course, if you have problems and you have access, and there are a lot of resources now, especially as for providers, is therapy. It has really helped me a lot in terms of processing my own emotions. And I highly recommend it for you, and I highly recommend it for your patients as well. The last thing is meditation. So the research shows that if you do 90 minutes a week, which is 7 minutes twice a day, it decreases the stress response. It decreases the volume of the amygdala seen on the MRI, increases the frontal cortex structures, increase gray matter in the brain. It also increases cortical thickening in other areas involved in hippocampal areas, which is involved in memory, and increases the subjective sense of well-being. It increases the immune system response. There are easy ways to access. There's many organizations now for patients and for you. There's apps, Headspace, Calm. Those are the two that are the biggest ones. And if you're a physician, you're saying to me, oh, I can't do that. I can't sit in my office and meditate. I don't have time. I can't do it at home. I have kids. I don't have 7 minutes. I don't have that time. Well, I'm going to tell you a place in the hospital you can go where nobody ever is. And that's the chapel. This is the one in Good Samaritan Hospital downtown here in LA. I've been in there. I've gone there for 9 years. I've never, ever seen anybody in there. You can go during lunch. Just take some time out, take some deep breaths so you can have what I call responsibility. And that's the ability to respond. So if you have this responsibility instead of a reactability, because you've taken care of yourself, then you can get to what is your responsibility. So as physicians, what's our responsibility? You know, most of us are not working with kids, and this is where we see patients here in this area. They're coming here. They're having diseases already. And a lot of the stuff I talked about is happening earlier on. But as I showed you in that Diaz research, you can reverse this. You can help reverse this process, and it requires you to listen for signs of trauma. So there are many, we talked about them already, but depression, anxiety, insomnia, stress, overwhelm. And a very simple, practical thing is to add an ACEs survey to your social history intake. So even before you see the patient, you just flip to that page. There's some online. You can go to Google and download a very simple 15 ACEs survey. And it's a yes, no thing, just a screener, just to see if they have it, so you can go into it more. Then if they do have it, have an active list of referral sources in your area, therapists, counseling, things that you actually don't have time for, but other people have training and time for and can get paid to do it. And the last thing is trauma-informed care, which is an approach, and you can do your own research on this, but it's basically an approach of approaching the patient with an attitude of what happened to you instead of what's the matter with you. So hearing what they have to say. It's about listening, about being compassionate. And again, in the end, though, it really comes back to how you're taking care of yourself. If you're taking care of yourself, if you're giving yourself that compassion, then you can give it to other people using these techniques. I really appreciate you all listening and staying on board with this. I really think it's an important time for physicians. And there's a lot we can do. And it's a state of humility, a state of compassion, and a state of listening. Thank you so much for listening.
Thank you very much, Dr. Vongtama. That was a fantastic presentation. I really enjoyed it.
Thank you.
If it's okay with you, we have some questions coming in.
Sure.
The first question we have is, approximately how long can the effects of overwhelming amounts of stress stay within the body?
That's a good question. So when we're talking about the stress response, we're talking about epinephrine, norepinephrine, and if it's not re-triggered, it's usually within 10 to 20 minutes, it starts to dissipate. If you add in deep breathing, if you add in what I call triangular breathing, which is inhaling, holding, and then exhaling, taking this type of breathing approach where you're controlling your breathing, it can decrease the stress response even more. So if they can tolerate it for about 10 minutes or so without doing anything or reacting, it should start to dissipate at that point.
Thank you very much.
Sure.
We have another question that comes to us from Rachel McCarley. Her question is, what about people of color's impact of trauma and changes in the limbic system at pre-verbal stages?
That's an interesting point. So I skipped that portion, but it's a good question. There's a lot of research coming out now about in utero exposure and prenatal exposure. That's one aspect of that. I know she's talking about pre-development, but a lot of the complex PTSD they're seeing is prior to the development of the mature brain. So it's if you, just as a common sense thing as well, it makes sense that if your brain is not fully developed, it's going to cause more trauma in those brains. And the interesting thing in the research is finding that in utero exposure, in utero trauma to the mother is affecting the brain structure and function of the neonate as it comes out of the womb. This is very interesting research. It's a very good question.
Thank you. We have another question. Do you know of research regarding the link of faith and resiliency and trauma?
Yeah, that was a part of my own presentation. I don't know specifically data in terms of faith and resiliency, but a lot of faith-based practice is resilient practice. The tenets of resiliency are compassion, meditation, forgiveness, which is a big part of faith, and all faiths have very similar arcs for that. So I would suspect if you looked at the resilience research, it would show that the faith-based practices are very similar. I can't say for sure if there's actual study looking at Christianity or Buddhism in terms of resiliency or anything like that.
Okay, thank you. Switching gears a little bit, a question came in, how can we overcome the anxiety of post-COVID life, such as reintegrating into regular life, returning to work and school, attending larger scale events like sports games, concerts, and other community events?
Yeah, that's a really big question. I get that a lot already. It's it's causing me stress. I tell you that too. I think it's causing us all stress. And there's a huge factor here of the unknown, and I think that's what we all have to become more comfortable with. I have a coach, Kate McGregor Stewart. She always says the unknown is the creative space. And when I first studied with her acting, I'd say, like, I don't like that. I don't like the unknown. I want to have everything planned out. I want it clear. And she's like, of course you do. That's what everybody wants. But a lot of it is tolerating the unknown and following the best guidance of our epidemiologists like Dr. Fauci. And then on a personal level, just being smart. A lot of people are reintegrating extended family now. I know even personally, people are allowing grandparents to come in. And I personally have been getting nervous about that because we don't have a real treatment yet. We're just getting antivirals. We're just seeing the first studies. And the best thing that we can do right now is social distance still. So if there's no need to come in, it's really better to limit. The vaccine should be coming out, early 2021. They're saying, Dr. Fauci said they'll have over 200 million vials ready by the early 2021. And then, that'll be another debate, of course, because a lot of people don't believe in the vaccines. I saw this study and they found that 44% of Fox viewers believe there will be a digital tracking device implanted in the vaccine, and 22% of CNN viewers believe that there'll be a digital tracking device placed in the vaccine. So the medical establishment definitely has a large role to play coming up. I diverged from the answer, but anyway.
No, thank you very much. I think that was a very interesting divergence. Another question that came in, can you touch on whether or not there is a connection between vitamin D consumption and successful COVID outcome?
That's an area of research. So, I mean, this is actually that part of the talk that I was going to give on Wednesday. A lot of the research coming out now is what we call pre-peer review. And a lot of the news outlets are picking up on these studies before they're actually becoming validated. And as Dr. Silvestri, Dr. Dean Kane, we all know that studies and research are a moving target. There's a big unknown factor. And with vitamin D specifically, vitamin D is integral to the immune system for sure. Now, that's not debated by anybody. The question is what to do about it. Do you need to go into the sun? Because sun conversion causes vitamin D to go to the active form. How much sun do you need? It depends where you live. Below the 37th latitude is the only place in the wintertime where sun actually does vitamin D conversion through the skin. So then people are talking about, well, I should supplement. Well, you could supplement, except that supplementation, vitamin D, people don't know, is actually a fat-soluble vitamin. So the more you take of it, it can give you a side effect of actual calcium dysregulation. It can affect your calcium. So what I say to people is, if you're really concerned about vitamin D, go to your doctor, get a test, check your level. If it's low, he'll help you figure out what dosing you need to have. I don't want to tell people blanket recommendation. Some people will be fine just getting it from the sun. Some people need supplementation, especially given darker skin tones, because of melanin production. So it's a complicated answer. It could be a whole hour-long talk, but it's a very good question.
Thank you. One last question for you.
Sure.
How can we best talk to our children about this traumatic time?
That's another really good question. I think it's age dependent. I work a lot with youth too. We have this question: how do you talk to children about this COVID-19, even about the I can't breathe? There's a lot of complexity in there, and I really think every parent has a different challenge. But I think it has to come when you sit with your kids from a place of calmness, from a place of peace. So you're modeling that they're safe because you're safe. Not because you're telling them that they're safe, but because you're actually safe. Like we talked about in the talk about getting a practice, a relaxation practice or a meditation practice, doing journaling, getting that place before you sit with them. So when you sit with them, you can actually speak whatever you feel. I don't think it's about word choice here. It's really about, what are you actually experiencing in your heart and in your body and in your being when you're sitting with your kids and talking about these topics? Because it's difficult, and every parent, depending on what race they are going to talk to their kids differently. I have my African-American friends. It's a sad discussion for a lot of them, because especially if it's an African-American male child, it's a different discussion than if it's a Caucasian child, because the risks of their life is completely different. So it's really about how you're approaching the conversation in your heart. Are you approaching it with anxiety? Are you approaching it with fear? Are you approaching it with sadness? Are you approaching it with anger? Those are the things you have to make sure you have a grip on before you have a discussion with your kids about any difficult topic, whether it's COVID, whether it's George Floyd, or whether it's just life in general, I think.
Thank you. That's excellent advice. And just want to thank you again for all of your work in advocating for how to move forward with everything that we're dealing with in our world at this time. It's alumni like Dr. Vongtama that make our school so proud and serve as an example for the students and residents as they explore the many career options available to them. We're also proud of our distinguished alumni and congratulate everyone who is celebrating a reunion this year. On behalf of the Jacobs School, we share our heartfelt gratitude to all of you who are working on the front line or have been impacted by all of the trauma over the past several months. We encourage our alumni to please be on the lookout for opportunities to help welcome our newest graduates who are moving to a city near you to train for residency. Lastly, please note that today's program was recorded and will be shared along with our post-program CME survey for those of you who are interested. Thank you for joining us today, and I hope you enjoy the rest of your day. Be well.
Well done, everybody. Roy, that was fantastic. Thank you.
No, thank you.